All right, welcome back. We're continuing with our conversation on the drug addiction burden here in Mombasa County and some of the interventions that state actors, the county government and NGOs are employing to deal with it. Professor, let me come to you from the NACADA perspective, extremely important when it comes to policy that hopefully can be implemented on the ground. What is your organization doing to tackle this particular issue of drug abuse across the country?
Thank you. This campaign against alcohol and drug abuse in the country is anchored in legislation through Acts of Parliament. Yeah. And basically we have 3 Acts of Parliament. We have the NACADA Act of 2012, and that is the one which gives the authority mandate to coordinate that fight, that campaign against alcohol and drug abuse. And of course, NACADA basically brings together the other actors, both state and non-state actors. Right. And through that, there are programs which are, undertaken. We also have the ADCA Act, the Alcoholic Drinks Control Act of 2010. That is what is generally known as the Mutuzo Act, actually. And that is the act which now controls the use of especially alcohol. The time one can open their bars, the distance between where you are not supposed to have a bar, from a school, an institution of learning, and, things to do with underage drinking and such things, So that act now sets the conditions, the regulations, the laws, which must be followed, especially when we are talking about alcohol. Then, of course, we have the Narcotic Drugs and Psychotropic Substances Act of 1994. And that act is actually the one now which deals with the hard drugs now. Okay. And it sets out the fines, it classifies the drugs, and also sets up the fines which are imposed once you are caught with these drugs and so on. So that is basically the framework through which this fight against alcohol and drug abuse is driven. And then we have programs within all that. For example, in NACADA we have the public education, which is the main driving. That's the public education, where we go to the public and talk about why you should abstain, why you should not be taking alcohol, drugs, and things like that. So we also have counseling and rehabilitation programs. We also carry research on alcohol and drug abuse, ADA. We set up policies, we support county governments as far as alcohol and drug abuse is concerned. So there are programs dealing with students and pupils, life skills, training, where we tell the young kids how best they can resist the temptation, how they can say no, to such drugs. And therefore, we collaborate with the civil society in all this. This is not just a war for one organization. It is for everybody. Everybody has a role to play. So we have been collaborating with many of the stakeholders. Yeah.
You've mentioned 3 laws that exist in dealing with drug and alcohol abuse in this country. Do you find them effective? We're talking about Mombasa that used to be a transit. Now it's a destination. Have those laws evolved with the reality that we're facing now?
I think the laws are not strong enough. I wouldn't say they are effective. Of course, to some extent they are, but you still find bars open at 10 in the AM. You still find people drunk, at noon. And yet, generally speaking, bars are supposed to be opened at 5, and they are supposed to close at 11. I mean, so there is a lot of illicit, substances which are not covered within the mainstream, law, the mainstream legal framework. And therefore, you find that these are illicits, you know, they are done underground, you know, and therefore it is difficult to enforce. But of course, if we enlist the community and so on, maybe something must be done, and that can be put in policy, in legislation, so that we can strengthen these laws.
Absolutely. Let's shift gears slightly and go to the audience. I believe there's someone who has a personal story to share. Please give us your name and a bit about your recovery journey.
Okay, what I would like to say, to share with you guys and this, Musa is made from his past mistakes. And Musa has been I've been into drugs for a while. I was once hooked in heroin, but I found myself out. So after that, I've been working with local administration and the national administration, working closely with other CSOs to make sure that we help our brothers who are still into drugs. So I've been working closely with the addiction part. So I made myself out. So I've been using my real life experience to help my brothers, but it reached a point where I started, like, I needed some more theory on that. So I've been working hard to see that I change other people as well.
You mentioned that you work with the local administration, and we heard from Mohammed how difficult it is for someone who's come out of addiction, trying to reintegrate into society, trying to find work, dealing with stigma. How did you deal with that?
Okay, I had that. I had the will. Yeah. That will gave me that power to make that change. So I have that will. I had that will. So I changed others through that real life experience. Yeah.
You know, Taib, let me come to you, because you deal with so many Musas, to put it plainly. You know, people who've gone through addiction for years, they're trying to find themselves, and you're also dealing with a sick person, right? They need that help to come out. They need the psychosocial support, the medical treatment. How do you begin that journey when they come to your facilities, for instance?
Yeah, thank you very much. I think this is a continuous journey in terms of you really need to be well-trained. You need to understand the process. And when we sit in the office, we cannot see this. That's why we use the harm reduction program, to be able to reach out to them where they live, where they stay, where they inject, where they inhale, where they smoke, so that we can be able to give them that information and bring them back to the community. So what we do in the Reach Out Center is to be able to give that unconditional positive regard, to be able to bring them back to that loving care, understanding, and to give them hope that there is a way out from here. And this is, it's possible. We have people in the community who have come into a very bad stage, and they've been able to be taken through the counseling process, the assessment, psychosocial support, and this is geared or anchored into different level in terms of now the real thing of going out, inform them. Then we have the drug treatment and rehabilitation. This is where now the journey starts in terms of, now it's a 4-month program where you'll be taken through behavioral change approach, motivational interviewing, counseling, family integration, family involvement, group therapy, so that you can be able to understand the problem and being able to quit and come out into the process. Another area that we also involve mostly is the family intervention, where we bring in the family members to be able to reunite, bring them together, and this is towards many support that is needed within the community and also towards understanding. Another area that we also involve more is the advocacy program, where we know NACADA, the policy, you've put it very rightfully that we have policies but or laws that we are having, but they are not talking to the community. They are not community friendly. They are not human right friendly in terms of people who use drugs. They need to be at the center stage, that they can be able to be given opportunity. They can be able to say, this law is helping us. This area is not working. That we don't have. That's why we are championing the harm reduction policy in the country. And we're also looking into removing the addiction into the mental health. This has been Every time you mention addiction is geared towards or anchored in mental health. But we want it to be in public health, where we can be able to have resources, where we can be able to have programs, where we can be able to trickle down to the ward level. That is what our Governor Abdul Somad Sharif Nasser is looking into, where we can trickle down to the ward level, where we can be able to have ward managers who can be able to understand the community and look into the past 20 years that we haven't been able to put in the right fruits that we want to achieve. We have seen the light at the end of the tunnel that we are seeing now. For the first time, we have a government rehabilitation program. That is, NACADA has been able to work together with civil society organizations. My brother has mentioned the public-private partnership is key. We have a model, we have a unit that is talking to the community, is community friendly, is geared to the people who use drugs, and we are looking into having that, the idea that we're looking into to have the harm reduction policy or law in the country that can be able to look into the levies, to look into the areas that government is looking into and budget it. If it can be in the public health, we'll be able, happy, and see how we can be able to. The fourth area that we're looking into to be anchored is the livelihoods program. Because without the livelihoods program, we will do much, then that will go in the strain. But if we have some places, we have individuals, and that is what NACADA concept in Meritini is looking into, that we need to have a sustainability livelihoods for this community and bring them into the center stage, that they can be able to be meaningfully engaged, support into programming, be able to program together and execute the program together. And also monitoring and evaluation that can be able to work together. And lastly, what the Prof has mentioned, invest into research and innovation. How can we be able to work together with the government departments, the youth, the gender, that can be able to bring together and synergize the program so that we don't work in silos, but we work together and bring the efforts that we want to do.
I like how you put it, Taib, the light at the end of the tunnel. And you've been in this journey for many years, so I'm sure you are really, really hopeful about things changing. Let's go to a few questions in the audience. Please introduce yourself.
Okay, I'm Imelda Okulu, a member of the YWCA, that is Young Women Christian Association, and also a member of the Kuza Livelihood Improvement Program. In Vita Sub-County, I am the Youth Advisory Champion for Health Representative. My question goes directly to Dr. Masha. What are the strategies that are put in place to ensure ethical and meaningful involvement of adolescent girls and young women and youth at large in ensuring they are involved through this journey?
Okay. Let's take two more before we have Dr. Masha respond. Yes, the gentleman behind you. And then we'll come to you. Let's go to you. Yes, go ahead.
Thank you very much. Before I ask my questions, first I'd like to appreciate the effort by both the national government and the county government towards the fight towards this menace that is covering the entire coast region. But also, I would like to inquire, I think the entire panel can answer this. Anybody in their position can fail to answer. The war on drugs that we are fighting, how do we ensure that our youths and young people are not, do not end up as the collateral damage towards this? Because many a times we focus on fighting those who use drugs rather than fighting those who bring the drugs, or rather those who make it possible for them to exist in our region. Secondly, family reintegration is not so easy. And if I look at it, if a person starts using at a very young age, they end up being shunned away from their family. How then do we focus on building that family support? It must be very difficult, but then how do we still make it possible? Towards the concept of sustainable livelihood. We're living at an age and time where education in Kenya is really advanced, and so many people are slowly getting acquainted to an intellectual livelihood and lifestyle. But then, while this is growing, also is the number of youths and young people who are still unemployed. So if it is still difficult for an educated youth to be employed, how then do we come to create an environment where someone who was not educated, someone who is shunned away from the family, and someone who has no skill set will still be able to get equal opportunity of employment. I think that those will be my 2 areas of interest.
Thank you. We'll take one last question from, yes, go ahead.
Good evening. My name is Betty Sharon. I am the Executive Director of Collaboration of Women in Development, and I also chair Health and Gender thematic area for Civil Society Network, COAST. My question is directed to Dr. Masha. And before I ask the question, I too am going to appreciate the hard work and good work that all the panels are doing, or not only in Mombasa County, but in Kenya as a whole. Dr. Masha, you talked with a lot of passion about prevention. But how do we focus on prevention when we are not focusing on voluntary and counseling and voluntary testing? We have lost testing. And the last data shows that we have increased new infection in the youth and adolescents. Now, when we are talking of prevention and treatment, how are we treating before testing? And now we also have home testing, and we have testing kit in the pharmacy and chemist. How are we interlinking with the private sector to ensure that those who are buying the home testing kits are cancelled? We are living in an era where mental health, the data also shows that 4% of Kenyans are suffering of mental health. Suicide is high. My brother here, Taib, has talked of research. Have we done the research of where suicide is coming from? Could it be that those who are doing home testing without counseling, some of them are the ones who are ending up in committing suicide? Are some of these people also deciding to spread the infection? Are some of them getting into stress and depression? If we are not testing, then what are we treating? Thank you.
Thank you. Thank you so much, Dr. Sharon. So we'll come to you, Dr. Masha, to respond to the 2 questions directed at you and then to the rest of the panel. Go ahead.
Thank you very much. So the first question was, what policies do we have for adolescents and young people, and how do we meaningfully engage them? I think the adolescents and young people program is at the center of many of the health programs within the Ministry of Health. And in the HIV sector, adolescents and young people are actually prioritized as vulnerable populations. And in terms of policies that we have, the anchoring policy, we do identify the need to engage adolescents and young people. And we have a program as an institution that runs across 47 counties just to ensure that we can hear the voices of the young people, the adolescents, in the design of the programs that are targeting them. I know that may not be enough in terms of what we are currently doing, but I think that has been, in the last couple of years, our center of attention. And we did identify a couple of issues with the adolescent and young people. And one was the new HIV infections. Secondly, we did identify adolescent pregnancies. And thirdly, we did identify sexual and gender-based violence. And all these things were interconnected. And now we have added alcohol, drug, and substance use disorders because we have seen also what is also happening to our boy child. And as we've been going across the country trying to bring adolescents with us at the center of this discussion, we realized that we have quite a number of unaddressed sexual and gender-based violence cases for adolescents and young people. And also we've been asking ourselves, when we talk about 10-year-old, 14-year-old pregnant adolescents, children, they did not have the consent they cannot give consent for sex. So basically we have been labeling pregnancies that are as a result of defilement, and we forget the issue of the defilement and focus on the outcome of that defilement. So we are really working very hard to ensure that, and that is why we put a campaign called Eliminating the Triple Threat. And we said that let's be accountable as adults for these adolescents. While it's enough and good enough for them to be at the table, these are children. They need adults who are responsible enough. And we are using the Nyumba Kumi approach with Ministry of Interior and Government Coordination and other partners, and saying that from the small 10 houses, can you account for every child? If a child is pregnant, who made that child pregnant? Can the community take this responsibility and begin both the preventive lens, but also trying to see how they become accountable? So yes, you adolescents are part of the group that we really focus on, and we have a Maisha youth group that is across the country where we have 47 chapters and ensure that they're all engaged within the program. The other question that you did ask was, was about family. And this really, for me, is where the challenge lies. And I have been in this field of drug and substance use with Taibia for close to 20 years now. I mean, they were taking me to the den when I was a very, very young girl. And really the challenge of trying to bring families to understand their kin. And these are not just, not because of poverty, for example. These are families that are as desperate as the drug user themselves. They have tried everything possible. They showed love and the person showed the opposite. We also need to remember that drug use is associated to crime.
Yeah.
So they'll have taken the handbag, the spoons from the home, they have destroyed the social fabric, the trust, and to rebuild that, you rightly say it's very, very difficult, but we must do public education. And not just awareness, because for a long time, everybody is aware, but education means people understand what they're dealing with. I've met a number of parents who, I keep saying, when they have a child who has already gotten a disorder, they for example, just say, let's resort to prayer. Prayer works. It's a social support, but you also have to look for an intervening intervention that works. Prayers plus giving them the medical assistance. And if the family is educated to realize that they are dealing with something beyond themselves and they can get help elsewhere, and that help is what, for example, we are very happy to see that Nakanda government-owned facility in Miritini having both inpatient and outpatient capacity that is complementing the other facilities we have across the public sectors. And we are beginning to say we are now recognizing that this is an issue that we all have to come together and families have to be there. The question about, of course, people who inject drugs being left behind in terms of skill set, and I think the county government has, and I'm sure they can add to that. Kenya, interesting, the average of drug and alcohol, the average years of drug and alcohol use is lower than the global one, because ours is about 11 years of age as compared to 16 to 19. So that means we have taken the age to more towards the children. And if an 11-year-old starts using drug, 12, 13. So as he rightfully said, the skill set is not there. And we were discussing this today and asking ourselves, so what next? Can we start working in partnership with other agencies, and then when we have them in the treatment program, we can begin to see how we take them back to school. Most of them have been left behind by their age mates, way back. I met today a young woman who said she scored a C, and she came from up country, found herself in Mombasa, hooked up in drugs, and she was trying to tell me, now, can you take me back to school? And not only her, I have met bankers, lawyers, and all these kind of people who went to the den and a part of their life has gone.
Right.
So if you're talking about reintegration, then we must begin to treat this group as a special group. Because if you put them at par with other society members and start comparing if they have a degree or not have a degree before we give them an opportunity to redeem themselves, then we will not be able to achieve that. So I like Mombasa County saying that this is a special group and they need love, they need an intervention. And what pained me, Victoria, today is a group like this sitting down, we have given them treatment and then they sit down the whole day. I mean, if there was something that we have for them to do,
right,
then they would begin, in addition to being healthy, they'll start beginning to see some hope. Finally, the issue of test kits. I want to just re-emphasize that self-test kits have never been associated with suicide, because the self-test kit procedure involves counseling. In fact, you can even work with a counselor from the time you open that kit but to the time you test yourself. And there's also a referral mechanism. And I think the World Health Organization has done many studies, followed up the use of test kits, and I can just confirm that those studies have never really shown that if somebody has the agency to diagnose themselves, they indeed can commit suicide. However, we still have very high suicide rates as a result of HIV diagnosis. Not necessarily the one who has tested themselves. And that is because we have not worked on the mental health issue. And we are beginning to say mental health has to be aligned with any diagnosis of a chronic illness. And for most of us here who have gone for an HIV test, it's not easy. Today, if I just bring one here and I just say, let's test, and we wait for the results, the next few minutes, there's a whole mental turmoil. And then if you give you the results today, and then I follow you up and say tomorrow, then immediately I tell you the results, then I say, these are the ARVs. So I'm giving you diagnosis, I'm giving you the drugs at the same time. So I have not addressed a component of your mental health. And it is rightful that we have to give you the drugs. So I do agree that we have to do the mental health issue. And finally, test kits. Test kits are available right now as we're speaking within the facilities. But the question is, do we have the volumes of test kits that used to have before? The answer is no, because external resources have reduced. The strategies for testing have also changed over time. And we do have targeted diagnosis test kits. And then she rightly said, are we partnering with the private sector? And that is the way to go. We have to sustain this program and design them the way you're saying, because we cannot delay diagnosis because of test kits. We have to think about, this is a disease that we have to universally provide a kit for anyone in need for it, and they are able to be diagnosed and put on treatment. So I think with those few remarks, and I'm available after this session, just to have more discussion about test kits and diagnosis of HIV and how it is important for us to align it with the mental health. Thank you.
Fantastic. We'll take one more round of questions, but there was a very critical question on dealing with the source of the drugs. So, yeah, Taib, if you want to handle that, and also Mohammed, if we can come to you.
Yeah, thank you very much. You brought in a very important topic that many people shy away to be able to talk about this. Is very passionate talking about this because we have seen thousands of people, we have seen people in rehabilitation, we have seen people dying in the community, we have seen violence, stigma around us. And the movement or the community and the way the government is looking into is that war on drugs. And to be true, Victoria, is war on drugs is war on people who use drugs. That is what is needed. That is what the analysis is all about. We haven't seen a war on drugs internationally, worldwide, that is focused towards the people who bring, cultivate, sell. but we will go down to the users. And that is where that hurts me. That's the point that really put off the work, the efforts that we do. Today we go the efforts of bringing in the intervention, bringing in the services. Then later on we see raids in the community are done and people are taken to prison. Because of a statement, one statement that has been given, we want to close down these raids. So we're urging our government, we're urging the president also to look into people who use drugs like human beings, to be given a second chance, to be given treatment, and let's not talk about war on drugs, because war on drugs has failed many years. We haven't seen a country that has said that we are fighting on drugs and they won. But if you can be able to put in strategies, to put in measures, ideologies can change, and rightfully, Prof has mentioned it here. Yes, we have laws. We have laws that we've inherited for many years, that we haven't changed them. We had the Act of 1994 that stayed for more than 30 years, that we haven't looked into it. Then we looked into it and we make it more punitive than to bring it to human rights. We are looking into it. We saw a chance in 2020, 2022 that we see this is a peak of it, that we want to bring it now to human rights. Then it's become more punitive. It becomes more not friendly to people who use drugs, but pushing them away. So we really need to see the challenges in terms of how best we can be able to look into 3 areas. That is harm reduction, demand reduction, and supply reduction. Of course, we advocate for the supply reduction, but needs to be done with very intellectual and also very good interviews to be done and to have the exact people who are bringing.
Mohammed, we'll come to you then. Prof will have you respond.
Thank you, Vicky. I'll talk about first on the employment issues, the question which came from the panel. As a county, we are advocating for those who have been recovered, having that plan of ensuring that they're engaged in terms of either internship or employment opportunity. Subsequently, we have quite a number who lack the skill set. So with this, there are also plans with the county leadership who have earmarked. Normally the county collect liquor revenue through the liquor licensing. The county government of Mombasa will now be allocating a small amount back to the treatment of drug and substance abuse through the MAT clinic and through rehabilitation. The governor right now is looking forward, even for the county government of Mombasa, to have public rehabilitation. At the moment, we only have CSO-owned or the national government and NACADA rehabilitation. So Honorable Abdul Samad, fighting the war against the drugs, he's really keen in the county government of Mombasa having public rehabilitation centers whereby we can reinforce the fight and be able to rehabilitate the people who have been hooked to this. So part and parcel of that is working closely, collaborating with the technical and vocational or training center to ensure that those who are at zero skills be able to get even small skills in terms of handwork and be able to be linked to somewhere where they can have some engagement and daily bread. Coming to the issue about supply, as the Mombasa County government, in the Department of Health, the focus has been looking at demand reduction, which my brother here said, working closely, ensuring that we work with the CSO, ensuring we work with other partners to ensure that we get those people who are hooked on the drugs, to ensure that they are put into different programs and the demand for the drugs goes down. However, I've been their discussion and I've discussed with the government department, both NSDCC and NACADA, to be able to have a collaborative effort whereby globally there's that fight through the anti-narcotic. In Kenya, it is also there, and that fight is also there for the drug. But these things run parallel. Yeah. The health sector ran with the demand reduction, the other anti-narcotic ran with the supply cut parallel. But there's need to bring these two units to work together to ensure that they forge a formidable way forward to cut this menace of drug and substance abuse.
Okay. Prof?
Yeah, thank you. The issue of youth and drugs in Kenya is really, the picture is very bad. And we risk losing a generation, you know, because of this problem. We've done research on the alcohol and drug abuse in primary schools. And we find that, of course, we've mentioned the age of initiation being as low as 11 years. We found that nearly 4% of the kids in primary schools are active users, current users, meaning that they are using, you know, they are smoking, they are using, you know, whatever kind of drug. When you go to secondary schools, you'll find the situation is even worse at 7% against a national, rate of 12%. And therefore, the problem starts very, very early, you know, and it grows and grows. By the time these people are going to university and colleges, they are already hard drug users. And you know, it now becomes a challenge at that level. And I think when we ask, where are they getting the drugs from? Not the hard drugs, but the other drugs like alcohol and so on. Actually, the culprits here are the parents. Most of them, you'll find that they learn them from their parents. You know, they are going with their parents to the bars. You know, the parents are drinking when the kids are playing around. What do you expect? I mean, to them it is normal. The parents are buying, you know, liquor and taking it to their homes. And when the parents are not there, the kids are taking the liquor and adding water or whatever they do. But you see, so it's the parents. The parents have run away from their responsibility, and they have left this to the teachers, and whatever, and then they are here lamenting. I think it's something we must really look at, you know, the parenting, you know, and maybe come up with the policies which should actually give parents the power to, you know, the parenting, you know, parental skills.
Right.
Yeah.
A breakdown of the social fabric, indeed. So let's go to the last round of questions as we wrap up in the interest of time. I see a few hands, so let's come to you, and then we're done for the evening. So go ahead.
Good evening. My name is Abdallah Shoaib, and I'm directing my question to Dr. Ruth.
Okay.
So, as a country, we have seen trends on HIV infection, burden of substance abuse among young people. And unfortunately, most of our programs depend on external resources, to be specific, donors. As an institution, what are you doing or intended to do to make sure that you implement programs without donors and to meet the needs of Kenyans, especially young people who have been infected with HIV and who are using drugs? Thank you.
Thank you. Yes.
Good evening. My name is Rocky Peter from Human Protection and Justice Organization. My question is direct to Prof. According to NACADA Act on Alcoholic Drink 2010, commonly known as Motudo Law, it was being implemented well when it started. We could see the places of alcohol being closed on time and even opened on time. And maybe if people were drinking, then the places were locked from outside. You couldn't know if they are inside. Today, what we are seeing is different. The alcohol is sold at any time of the day. What is NACADA doing? Because if you look at Music Copyright Association, they work with the police to come, take the music they don't want from the cyber. Now, with NACADA, it seems to be different. The duty is left to the police to handle. And how are they handling it? They come to the pubs, they do what is necessary, then they leave people to drink. So can NACADA wake up, and can NACADA tell us what it's doing to ensure that this comes to a stop? Thank you.
Thank you very much. Final one to you. Yes.
Good evening. My name's Lavenda. I'm
a member of Smiley Girls Youth Organization. And first of all, I'd like to thank the government of Mombasa for putting in place some policies and making sure that they achieve what they've put in place. So my question is, how have, it's an open question, how have you been able to incorporate the youths also to be part of the whole journey of ensuring there is light at the end of the tunnel? Like, for example, in the rehabilitation center that is in Miritini, because personally I come from Jomvu sub-county, how have you made sure that you walk the same path with the youths?
Thank you. And final question here.
My name is Marilyn Laini, Director of Kokoijo Africa. We work with sex workers. My first question goes to Taib. Taib, you realize that many people, or young girls or young women, start taking drugs before they get to adult age. And after rehabilitation, you realize that they are either 20s, about 20s or 30s, and they don't have any ID. So what is it that is in place to make sure that they also get something? At the end of the day, they can get their IDs, that they can also start working or do something substantial with their lives after rehabilitation. Because with the mental health that we are having in places in our small ways, we realize that when these girls get rehabilitated and they don't have the ID, they cannot do anything, they cannot get any employment. They again go back to what they used to do. So is there anything? Are there any measures in place to make, or partners that you're working closely with them to make sure that they get ID? Because at 30, where do you get the ID? Because there are so many things that come in play. And then another question I want to direct it to Dr. Masha. You realize that many girls, once they get pregnant at home, they transit to sex work. Once they transit to sex work, they become very desperate because they are children without identification to get any employment. And again, they have a responsibility of taking care of their children. So my question comes here, because once they transit to sex work, they come to our cohort. When they're in our cohort, it becomes very difficult for us to give some intervention. And given the fact that we have very limited condoms and very limited kits for testing, to give them the prevention services, I really wanted to know what is the age of consent so that we can be able to do our work without having the government on our backs. Thank you.
Thank you very much. I understand we have one or two university students with us. I want to hear from one of them before we wrap up. Anyone from the campuses, this is your moment, 15 minutes of fame to take. Yes. Let's get a mic to the young lady in the back.
Good evening. My name is Hilda Asena. I just completed my university education at the Technical University of Mombasa. And I would like to just ask the panel, apart from putting all this intervention in place, all the measures are taken, everything is well. Now I'm asking the cases of relapse. We have so many relapse cases. What are you doing about those cases? Thank you.
Thank you. Okay, so we can head back to the panel to respond. And as you're responding, to also give your final remarks. So Dr. Masha, let's begin with you and the questions that were directed at you.
Thank you very much. So I think the first question is about resources and what we are going to do when external resources are not there anymore. Are we still going to have programs? As an institution, our core mandate is actually to look at resources, both external and internal. And we are in a period which we call transition of funding streams, where we are aware that we'll continue getting less and less of donor funds, and we have to look for alternative resources either from the government or from the private sector. So what I could just assure you is that the HIV program is going to remain and engaging young people. The institutions are still there, and one of the things that we are doing is what we call progressively gap filling. We know for example, our focus right now is commodities, which have been alluded to, when we have around 10 billion gap. So we try to see how we start filling that gap. As those resources move out, we begin to fill them with the internal resources. The other strategy we have is actually what we are doing today, prevention. Because we cannot continue just having HIV and saying you have new infections and have a burden that is among the highest in the world and do nothing about the prevention part of it. So prevention is another way we are working on to be able to sustain the responses. So for the young people who inject drugs, it remains a priority for us across all the programs, even with the resources that are available now. So we want to assure you, for the people who inject drugs, the young people who inject drugs and who have HIV, they still remain the priority of the program in terms of ensuring that they access treatment, in terms of ensuring that they stay within the treatment cohort. The question about the crossover of sex work, at the center is a pregnancy, especially for young girls and adolescent girls. And this is where we have been coming back to say that before we even start talking about a mature minor, can we start getting accountable to this child that has become pregnant? And when we delay reintegration back to school, we end up where you're telling us, where then she crosses over and starts becoming a sex worker, and we start following her there. We know that, of course, with interventions through the Ministry of Education to account for every single child who is pregnant and has left school, to make sure they come back to school after delivery of the baby, is one of the strategies, and then stop them from crossing over to the other side. Most of these girls that we have met in the drugs den, the ones that are also, for example, in Malindi, a lot of them will tell you it all started with the pregnancy. So we are also working on that element of prevention of pregnancy also, because we can see where that is going. You rightfully asked the question, so when they are with you and you find them on the streets, what does that mean? Can you offer them services? One of the things that as the HIV program we have put in place is policies, and we are cognizant that small children on the street are actually being sexually exploited, because they cannot even negotiate for sex. They cannot even be, they're children. So the sexual exploitation that happens within that program is where we are really appreciative of people like you who then come back to us in the program and say, we have these young people, they are below age of 18, and I really appreciate the sex workers groups that have been really keen on this issue and saying that what we do with these young ones that you are finding in the street. And as a program, also with NASCOP, we have been looking at those young people and trying to see how do we program differently, but with the idea of them being reintegrated back to school, rather than us transitioning them as adults into something that we could actually stop. So if they are to make any decision, they are allowed to first get an intervention that breaks the cycle of where they are going towards back to the society, towards back to school. And that is why the Triple Threat campaign is also linked to you, so that you can be able to look at those girls, and again, as a specialized population, because then we can't lump them together with adults. And we look forward to working closely with you as an institution so that we can all come together and identify a workable solution for the ones who have started earning money in the street, and see how do we get them back to school, because education is the only tool we can give them to be able to change their lives. Final word, I just want to tell, especially the community of people who use drugs, that it's not over. Yeah. And just to give hope to families. I know, as we're speaking today, across the country, families are hurting. And they're hurting because a kin is having an alcohol or drug disorder. They have done everything possible. And we are saying, let's just first of all come together as a society and deal with this issue. And then we can be able to heal families and also accept our children back, because even if they use drugs, they're still our children, they're still our brothers, our sisters, and our husbands. And if we come together as a society, we'll be able to overcome the challenge. Thank you.
Thank you. Thank you so much, Dr. Masha. Prof, there was a question on bars compliance.
Thank you. The issue of enforcement. Now, but we don't want to run away from responsibility. but our new constitution actually took away the role of licensing bars from the national government to the county governments. The licensing, the bars you see around the outlets, the wines and spirits and everything is licensed by the county governments. And therefore we have noticed a huge increase in such outlets, because I'm sorry to say, a number of county governments use them as source of revenue. And therefore, you are finding that they are getting money out of these bars and these outlets, but they are not really enforcing the rules as they should. Actually, some of the counties have even gone ahead and changed the initial Mututo law and started opening bars at 10. They're saying, okay, bars can open at 10, which is even against the law. And therefore, you find such challenges, and these are the challenges which should be, looked at and harmonized. So, but of course, this issue of enforcement is a joint, effort. The police, NACADA, the county government, and so on. And I admit that it is a challenge which should be looked at. But there's another problem: the licensing of bars and outlets. Alcohol outlets have categories. So you find that there's a category known as bar and restaurant. That one allows you to have a beer, an alcoholic drink any time of the day, as long as you're having some food. So some people would go there and they put, kichwa ya mbuzi or something, and they are waiting, and they are taking the beer. What would you do? Because and you see now the county government has already licensed them as a bar and restaurant. Mtu ako hapo na mtura, alafu they are waiting for food. So it's a challenge, and these are the things we must really look at. A solution must be found anyway. Maybe my last word. I want to give a challenge also to our scientists. When we are talking of these methadone and so on, these are foreign, kind of interventions being brought to us. What were our forefathers doing? What were they using? Can our scientists come up with the local solutions, local ways of handling this? Because I'm sure they used to have, in my community, we used to have some herbs where our wazes would take. I was talking to Dr. and she was telling me that in their community, they used to bring some herbs. If you take the alcohol or whatever, you puke, then, it discourages you and something like that. I think we need, because it's very expensive, really, to be getting methadone and so on, if we can get a local solution, I think it can work.
Interesting, some indigenous solutions that we can tap into.
Oh, yeah.
Taib, the question, yes, go ahead.
To the question from the audience first, yes, we have invested into having a very good partnership with the immigration so that we can be able to see, of course, we identify that addiction is a disease and it's a process of recovery that is needed. And you can be able to focus a lot into your addiction and forgetting the basic thing of ID. Of course, we've invested into that, and we have worked closely with the Department of Immigration to be able to give the report and also work closely with the chief and the village elders around Mombasa County to be able to identify with the individuals so that we can be able to give good information and right information to the department so that the IDs can be processed through. And also bringing in the family support. And also towards the young girls and who are going into sex. Appreciate NSGCC for also impacting knowledge on the listen model. That has been a very effective way in terms of reaching out to young girls to be able to bring them back to a discussion, to safe spaces where they can be able to talk, engage, and also share the problem of not having an ID, so that is part and parcel as a holistic approach where we can be able to support. To the question of relapse, this is something which is really giving us nightmares in terms of how best can we be able to reduce the relapses. By a good friend of mine sitting there at the back, Murad Swale, will encourage us every day in the office that we should not give up. We know relapse are there, and people will relapse, but we don't want to give up and say we are defeated, but to give them the room and show them that there is a way. We know that addiction is a disease, recovery is a journey, is a process, so we will expect that relapse will be there. But we haven't invested much. Of course, within the government, we know that there is no very good investment in terms of aftercare program, in terms of follow-up program, or even us, because we have limited resource, diminishing of funding that we are looking into. We cannot employ everyone within Mombasa County or within the organization, but what do we have for sustainable livelihoods where people can be able to have hand skill where they can be able to upkeep themselves? And when we invest into this treatment and rehabilitation, we also look into the overall goal in terms of how best they can go back to the community and be able to work better. And that will be an answer of relapse prevention. To my closing remarks, I want also to appreciate and also encourage community members to be part and parcel of this process. I want religious leaders to be part and parcel of this problem. Imams, churches, Hindus, Buddhists, the way we can be able to bring together the efforts and see that this is a collective response where we can be able to see and work together. Family members, we want you also to be part and parcel of this movement, where we can be able to encourage. Of course, the young people are in this movement. We involve every young person because we believe in the prevention process, and those who are hooked into, give them space to be able to encourage themselves, and also appreciate the media. The media has been part and parcel of this journey, that they've been able to support us, to air the information, to give the factual information that has been very supportive. Lastly, to our governor, he has been very supportive and also helping us to be able to have ample space for this organization to be able to work, and also support that is given to the county to be able to support us. Thank you.
Thank you. Thank you so much. Mohammed.
Thank you, Vicky. First, I want to respond to a question about the youth being involved in the program. I think the approach that is being used both by the county government and the partners, the CSOs, is we have a peer-to-peer model of engaging especially the ladies in terms of recruitment to the program and in terms of follow-up and being monitoring. Through this, we have been able to ensure that more females, because this, as much as we're talking about the problem about drug and substance abuse, it is more heavy for the few ladies who have been engaged in drug and substance abuse. The HIV prevalence is much more higher. How they seek the treatment interventions, socially they shy away from seeking that. So we have been able to use the peer-to-peer model, using the recovered female peers, reaching to the others in terms of at the dens, engaging them and bringing them to the program. So this is there. And equally, the county government has a team. Yes, it's less, but it has a team of youthful peers who engaged as a psychologist and a medical social worker who equally engage at that level. In terms of relapse, there's a question about relapse. In treatment of substance use disorder or opioid dependence disease, relapse is part of the journey. There are several reasons that this person at a given time will relapse. But as the famous Swahili saying goes, kuteleza sio kuanguka. But if you decide to kuanguka kabisa, stay down, you will not have an effort to stand up. We have been working very closely with the CSOs to ensure that those who are in the program, we are monitoring them and ensuring that those who default, we are handy in following them up. Those who relapse, we are there to encourage them to get clean, get back in the program. So it's a journey that we work together with the treatment, with the counseling and all the other approaches, and multi-sector in terms of the approach from the different government agency and different NGOs and different CSOs. My last statement, one, I'd like to thank the county government leadership for having this forum and also for having us talking about this menace. Secondly, I'd like to appreciate the media for covering this. One key thing that I'd like to urge the media is, I know a lot has been covered in terms of what is the gap, what is this side that is painting a bad picture, they're injecting the dents and these other things. However, I'd like to urge the media also to cover the interventions that are being offered by the county government, which are really working and they're really good in terms of a step-by-step intervention of what is happening at the MAT clinic. These people, how they're enrolled, how they are put into methadone, how they are being stabilized, how they are being monitored, and in terms of maintenance. And those few who have been in the program for long, how are they being weaned off? And after weaning off, what is the follow-up procedure in terms of ensuring that this person can stay safe without relapsing back to the drug? So this is something that really also needs to be aired so that it can encourage those active users, and also the public can know that there is an intervention that you can access and this product can get treatment. Last statement, I'd like to echo what Taib has said. The fight against drug and substance use is not for the people who are seated here. It's not for the organizations who are here, NSDCC, NACADA, county government. It is for every one of us. Drug and substance abuse can affect anyone or any family member. So this is a fight that at every point, the important thing is, if you know something, you know that there's treatment, this person can be assisted, advocacy at your own level. Kindly ensure that this person is linked to the correct areas. At every given area, every one of us need to take part in terms of fighting for drug and substance abuse. With that, thank you so much, Vicky.
Thank you very much, and certainly ending on a note of hope. That's what this is all about. So I appreciate your time, Mohammed Wakazi, from a MAT coordinator from Mombasa County. Of course, Taib Abdulrahman, who is the director at Reach Out Network here in Mombasa. We also have Professor John Muteti, Director of Programs at NACADA for Research and Policy Development. Much appreciated. And of course, Dr. Ruth Laibon Masha, CEO of the National Syndemic Diseases Control Council. Absolutely fascinating, enlightening conversation. Thank you to the panel and to the audience as well. A round of applause for you and your insights. And of course, the team that has made this possible. We also have to thank Serena Beach Resort and Spa for giving us this space to have this conversation. This is only the beginning. And as was said by some of the panelists, this is a task, a challenge for every single Kenyan here in this country. You have a role to play in seeing this menace become a thing of the past. Thank you so much for watching. I'm Victoria Rubadiri. Take you now to your regular programming. Good night.